Welcome to GI alterations. This is chapter 41 in your text. GI issues, this is a huge thing in the world of pediatrics because nearly every single child will be affected by something, some sort of alteration in the GI system at some point in their life. Like everything else in babies, the GI system is also very immature. Where does digestion occur in adults? It occurs in the small intestine, right? Where does it occur in children? The duodenum. Babies have deficiencies in their digestive enzymes, specifically amylase, lipase, and trypsin until 4 to 6 months of age, which is why we delay introducing solids until then. That's also why babies are so gassy. So, what are the signs and symptoms of GI issues in children? Growth failure. This is defined as a weight below the third percentile, a BMI that is less than the fifth percentile, or a decrease in the established growth pattern. Spitting up and regurgitation. Well, if food cannot stay down, obviously we're not going to be doing any significant growing. Nausea, vomiting, diarrhea, and constipation. Constipation is defined as difficulty with passage of stool for 2 weeks or longer. Other people will tell you it's a lot less than 2 weeks, but technically your book says 2 weeks or longer. Encopresis is the stool stains that you find in underwear of kids, and it is a sign of constipation. Abdominal pain, distension, or GI bleeding. GI bleeding can be upper or lower. It can be acute or it can be chronic. But again, these are signs that we have some sort of GI issue going on. Jaundice, that is associated with liver dysfunction, which is a part of your GI system. Dysphagia, difficulty swallowing. Obviously, these are signs of you've got some kind of issue going on. Fever, which is interesting. Also tells you because lots of times when kids have a GI bug, sometimes they will run a fever with it. Your textbook goes into a lot about vitamins, protein, and mineral deficiencies. You have all had a nutrition course and you've had some nutrition content from your adult GI. So if you need to brush up on this, please use your text. Food allergies are also an issue in the pediatric realm. I had a friend who died from a peanut allergy when I was 11. And so I assume that you guys have already gone over anaphylaxis already, probably in your immune chapters where I think you guys actually talk about it. I want you guys to understand there is a difference in food allergies and food intolerance. An allergy, of course, is going to be something that produces or has a reproducible effect, and it stimulates the immune system when you eat something or ingest something. An intolerance means that there is a reproducible effect, but it's not likely from an immunological standpoint. It doesn't come from the immune system. So there is a little bit of a difference. Now, the average layperson sees it all lumped in together. So when you're taking health histories, parents are likely to say they're allergic to wheat. Okay, are they allergic to wheat or is it just a wheat intolerance? If they eat wheat, are they going to go into anaphylaxis and die, or are they going to get a really bad bellyache? These are the sort of questions you kind of have to ask. My son does not tolerate a lot of wheat products well because he has celiac. But I always tell, teachers, I'm like, first day of school and they're going over this and that. I'm like, it's not an allergy. If you accidentally, if he ends up eating crackers or eating brownies at the class party, don't freak out. He's not going to go into anaphylaxis and die. He may just get a bellyache later, but he's not going to die. So it's important to kind of differentiate that. Food allergy manifestations, these occur from IgE mediated or IgE non mediated immune responses. The body is exposed to allergens, and that can make IgE antibodies when ingested. For oral allergies, it's usually something from fruit or vegetables. When eaten, they cause edema, itching from the lips, tongue, palate, and throat. Recovery is usually pretty rapid. If a child has a parent with a food allergy, they have a 50% greater risk of developing a food allergy too. Common triggers, again, nuts, eggs, wheat, legumes, fish or shellfish, soy, chocolate milk, not chocolate milk, chocolate milk, buckwheat, pork, chicken, strawberries, melon, pineapple, corn, citrus fruits, tomatoes, and spices. Pretty much anything and everything, I feel like I just said. For reasons unknown, most children are allergic to eggs. Most of the children who are allergic to eggs and milk outgrow the allergy by 3 to 5 years of age. No idea why. I will tell you there's some interesting studies that have come out on food allergies, and there is some research that will support that the earlier children start taking antibiotics, antibiotics, as you know, generally like, for ear infections or, things like that. But when babies are given lots of antibiotics, then it changes the normal flora, like your normal flora gut bacteria. And as you guys know, a lot of the immune system is located in the gut. So if you're changing what's supposed to be there, you're altering the immune system. There's a hypothesis that says that is why so many kids have food allergies nowadays than there were, 20 years ago or even 50 years ago. Because then food allergies were pretty much unheard of. So, one hypothesis is that, if you want to eliminate food allergies, and this is what they're trying, is that you have to recolonize the gut, and try and reset the gut and kind of remanufacture, I guess you could say. You kind of reverse engineer some gut bacteria and try and kind of reprogram the immune system to function as it was supposed to instead of functioning at this, hyper response level. I don't know if it's true or not. We'll just have to wait for more research to come out, but it's interesting food for thought, right? And now we will start talking about some GI dysfunction. The biggest thing that affects children is dehydration. Obviously, dehydration occurs when your total output of fluid exceeds the total intake. This is so common in children. All right, so isotonic dehydration results from the loss of water at the extracellular side, which reduces the plasma volume and circulating blood volume. This type of dehydration can lead to hypovolemic shock. Serum sodium levels will stay within range though, which is around 130 to 150. I always grew up and it was 135 to 145, but now we've kind of expanded the range a little bit. So, hypotonic dehydration. This is when the physical signs are more severe with small volume losses than with isotonic dehydration. Serum sodium levels will become hyponatremic. With hypertonic dehydration, this happens when water is lost and the concentration of electrolytes goes up. Serum sodium levels exceed 150. When your sodium levels go up, what do we have to look at? Yes, you guys are so smart. Watch for changes in their LOC, poor attention, poor focus, lethargy, increased muscle tone with hyperreflexia, hyperirritability to stimuli. Sounds like a lot of neuro responses, right? This type of dehydration can cause permanent CNS damage. Some of your signs and symptoms of dehydration: tachycardia, dry skin, dry mucous membranes, sunken fontanelles in babies, coolness or mottling of the skin, loss of skin elasticity, prolonged cap refill time. You know the drill. Compensation mechanisms. The first thing the body's going to do is to attempt to maintain blood volume. So interstitial fluid moves into the vascular compartment to maintain blood volume in response to the hemoconcentration and hypovolemia. And then you get some vasoconstriction of your peripheral arterioles, and that helps to maintain the central circulation. Pretty easy peasy, right? When the fluid volume is so great that it cannot be compensated anymore, then the blood pressure is going to start to fall and tissue perfusion is compromised. This leads to hypoxia, which is, and that leads to the accumulation of lactic acid from anaerobic metabolism, pyruvic acid, which leads to metabolic acidosis. Ultimately, this is going to lead to shock. Now, the kidneys are also going to do their part to compensate. Kidneys, in response to hypovolemia, they're going to concentrate the urine down to help conserve water. They say, it's all right. We don't have enough water. Hey, I can conserve water. Just let me help. Management of dehydration: oral rehydration for alert and oriented kids, and then we do IV rehydration sometimes if need be. I want to know how many of you guys have actually ever tasted Pedialyte, and if you haven't, I think you should, because it's disgusting. It's gross. If you can't expect kids to drink something disgusting because they're kids. They don't drink anything or eat anything that doesn't taste good. Your best bet is to sweeten it with some Kool-Aid. Um, One of the best sources of rehydration for kids is popsicles. Kids love popsicles, especially if they have a fever. It's one of the best things you can give them. Um, who cares how many popsicles they eat in there when they're sick, as long as they stay hydrated, right? If kids are vomiting, don't give them a big cup of water or juice or whatever you're going to think you're going to give them and say, drink it all. If they are thirsty, and they probably will be thirsty if they've been puking a lot, they're going to be tempted and they're going to want to drink a whole bunch. But if you put a bunch of fluid inside a belly that is angry and has been vomiting, the stomach's going to be like, nope, it's going to kick it right back out. So the best way to do oral rehydration is to rehydrate with 2 to 5 mils. That's like a sip. That's like one drink of liquid every 2 to 3 minutes. So that means you will probably have to give the child their cup, have them take a drink, and then pull it back away from them because they're going to be like, oh, that one drink tasted so good. And they're going to want to drink a whole bunch more. No, 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 no. Stomach can't handle that. It's still too angry, still too pissed in there. So one drink, pull it away, wait 2 or 3 minutes because then in 2 or 3 minutes, that 2 to 5 mLs will be nearly absorbed. So you're still keeping the stomach empty, but you're just getting by with just a little bit every 2 to 3 minutes. I hope that makes sense. IV rehydration involves an isotonic solution like normal saline or lactated ringers. The goal of phase 1 of IV rehydration is to expand volume quickly and to expand the circulatory and renal function. So a bolus of 20 mils per kilogram is given, and then it may be repeated, but that's sort of like your standard rehydration bolus dose. Phase 2 Phase 2 begins after the bolus, and that's to replace the deficits and the maintenance water and electrolyte replacements. And then phase 3, yay! Hopefully our child is doing better and is able to start taking fluids by mouth again. So you start cutting your IV rate back and you wean off IV fluid until you can switch back over to full PO intake again. Acute diarrhea is diarrhea that has lasted for less than 14 days, and it's usually associated with an upper respiratory infection, possibly a UTI, possibly with antibiotic use or laxative use. Acute infectious or infectious gastroenteritis. This is caused from a variety of pathogens, and we'll list those on the next slide. Chronic diarrhea, this is often caused from a malabsorption disease, an inflammatory bowel disorder, food allergies, food intolerance, things like that. This is the diarrhea that's lasted more than 14 days. Then in children, we also see something called chronic nonspecific, aka toddler's diarrhea. So this is common from age 6 months till 54 months. There's no known cause for it. Most children continue to grow. They don't show signs of malnutrition. They have loose stools with undigested food. It may be linked to food sensitivities and artificial sweeteners, but we don't really know. It just starts. I will tell you from a personal standpoint, my second child had toddler's diarrhea. And it started from when he was 1 year of age. Just started and he had diarrhea like every time he pooped, it was diarrhea. And I would find chunks of food in his diaper all the time. Now you expect to find corn, but I would find oranges, I would find green beans, I'd find chunks of tomato, like if he'd had spaghetti. Um, I found mandarin oranges in his diaper. Like I can still like, and it was weird. It wasn't like normal diarrhea. It was just weird. It was kind of like that, like the lawn and leaf trash bags that are kind of like that weird olive green color. His That was what his diarrhea looked like. It looked like trash bag. Looked like a messy trash bag in his diaper with food in it. It was so disgusting. And he had this toddler's diarrhea for from like age 1 until around age 3 when he potty trained. And then it just, it's like magically it appeared one day and magically it stopped one day. And we had him tested for everything under the sun and we found no explanation for it. So that's toddler's diarrhea. Obviously, with diarrhea, nursing management just means assessment of fluid and electrolyte imbalance. Make sure that kids are staying hydrated. You may have to do oral rehydration therapy, or if the diarrhea is really severe, usually it's going to be accompanied by vomiting too, but you can, I mean, IV rehydration is a possibility. But again, oral is better in kids if you can get away with it. Maintenance of fluid therapy. Um, Teach parents about diarrhea prevention. One of the biggest thing is wash your hands. um, so teach about personal hygiene. Make sure parents know to wash their hands, wash everything. Be very careful about food preparation. Again, wash your hands. Clean the water supply. Clean the water supply. Make sure the water supply is clean. Again, in the US, it's really not a huge deal because most of our water is pretty clean all the time. But, if you're ever on a missions trip and you're in a third world country like Nicaragua, um, then you might need to, evaluate how clean the water supply is. Also, you should just know that rotavirus, there is a vaccine against rotavirus. It usually involves 2 doses. Um, And so that's always something nice to encourage to parents if they want to avoid, a rotavirus infection in their child. All right, Hirschsprung's disease. Um, so this is kind of a new thing. I don't know that a lot of you guys have really heard of this. Seems like every year when I teach this, students are always like, I've never heard of this before. So basically, it's the absence of these autonomic parasympathetic nerve ganglion cells that you should have down in your rectum and colon. But when you don't have them, it prevents peristalsis at that point where the ganglion cells are absent, and thus kids can't poop, and they end up with an intestinal obstruction of poop. It's usually limited down to the rectosigmoid colon. Sometimes you look for babies who fail to pass meconium within that first 48 hours after they're born, or if they have a lot of abdominal distension or inflammation of the intestines, bloody diarrhea, things like that. In older children, you look for kids who aren't gaining weight, who show signs and symptoms of malnutrition. Maybe they have chronic constipation, fecal impaction, or a history of pencil thin stools, because that tells you if pencil thin stools, that tells you something's clogging up the pipes further up and just a little tiny bit of stool is getting out. The symptoms really depend on when it's diagnosed. So to diagnose Hirschsprung's disease, they'll start usually with a barium enema test, and then they'll do like an x-ray, and then if those things come up and they look abnormal, then they'll do a rectal biopsy. And so what they do is the pediatric surgeon will go in they go up through the rectum, and they just take tissue samples, and they keep sending them down to the lab like during the surgery, and they find the point at which those parasympathetic nerve ganglion cells stop. And then so what they do is they take out the bad part of the colon that is missing that. If they can, they'll pull the good part down and reattach it to the anal sphincter. But if too much of the colon is not innervated, then they will take and they'll pull it. Then they'll take what's left of the colon, and pull it up through the belly, and make a colostomy. So Hirschsprung's disease is corrected with surgery. Nursing care, again, this is kind of pre-op. You're going to place an NG tube. You'll keep the child on IV fluids because they're going to be in PO and we don't want them to get dehydrated. Why are we going to give antibiotics pre-op? Why would we do this? I will tell you. It's to prevent enterocolitis. Enterocolitis is a serious complication that can occur before, during, or after surgery because you're messing with gut. You're messing with potential for, bacteria, potential to spill poop out into the peritoneum. I'm just going to spell that out for you. So we're going to pre-treat with some antibiotics. Possibly you may have to administer some saline enemas pre-op, and then post-op, again, pain meds, vital signs, INO, and you wait for bowel sounds to recover so you know when the child can eat. Interestingly enough, I'll throw this in here too. Seems like with every system I've had a kid who's had issues with that system. So I have lots and lots of good kid stories for peds, which makes me makes me an interesting peds teacher, I guess. But my same son who had the toddler's diarrhea for 2 years, He was a constipated breastfed baby. Like the whole first year, after 3 months of age, he stopped pooping. And the only way he would poop is with actual rectal stimulation. So when I took him back to the doctor and said he's not pooping, um, they evaluated him. We had to go do the barium enema test, and we wanted to rule out Hirschsprung's disease, which we did. He just had to go on Miralax for the first year, and then when we weaned off of it after he was a year of age, that's when toddler's diarrhea kicked in for the next 2 years. We'll get to more stories on him in a few slides because he's had a lot of GI issues. Okay, so let's talk about reflux and GERD for a little bit. First of all, there is a difference between plain old reflux and GERD. Plain old GI reflux affects 50% of infants 0 to 3 months of age. 50%. That's a pretty large percentage. You get a higher incidence in preemies, and males are affected 3 times more than females. With just plain old reflux, babies are still going to gain weight. They don't have excessive crying. They don't develop esophagitis. Yes, they spit up, but overall, they still gain weight. In contrast, and we'll flip to the next slide. In contrast, GERD is characterized by poor weight gain. These kids sometimes get labeled failure to thrive. Lots of crying, lots of arching of the neck. These are irritable babies. They cry, cry, cry. Persistent respiratory symptoms. Maybe they have apnea, cyanosis, wheezing, cough, pneumonia, things like that. GERD is much more serious. You can tell because the name disease is in it. So, GERD is going to require treatment. The first line of treatment is going to be to put them on a PPI. Sometimes they'll do Prilosec, sometimes they'll do Prevacid. Sometimes they do H2 blockers like Zantac or Pepcid. Oftentimes they start with Zantac first. Oddly enough, babies will take Zantac down, liquid Zantac. You squirt it in their mouth. It's kind of a weird minty, pepperminty smell. They don't care. They just drink it down. It's such a tiny spit that they get. And then the surgery that they can do is the fundoplication. Basically what they do is they wrap the fundus of the stomach around the esophagus. G-tubes are usually inserted at that time to help vent the stomach and for feeding if need be.